We're so glad that you've chosen to spend your evening with us. Tonight, we're honored to have Dr. Strug here to guide us through the IVF process at Pacific Fertility Center. This is a great opportunity to gain valuable insight and better understand what to expect on your fertility journey. Throughout the presentation, feel free to submit any questions at any time using the chat or Q&A feature. We'll address as many as we can during the session and also have a moment afterward for questions and answers. As a special thank you for joining us tonight, we're offering a $99 new patient assessment for those without insurance coverage. This includes an initial consultation and a follow-up ultrasound, and it's a great first step towards understanding your fertility journey, and oftentimes is a great way to save some money as well. So let's get started, and with that, we will just welcome Dr. Strug.
My name is Dr. Mike Strug. I recently joined the practice back in September of 2024. I'm a reproductive endocrinology and infertility specialist, which is a fancy way of saying a fertility specialist. But all of us who are board eligible or board trained in REI first started out as OBGYNs and then did additional training to become fertility specialists. And a little bit of my background, I grew up actually on the East Coast in New Jersey and have slowly moved west for my medical training that I did at Michigan State and also did my residency for OBGYN at Michigan State and then subsequently went to Stanford for my reproductive endocrinology and infertility subspecialty training. And so here I am at Pacific Fertility Center now. So a little brief agenda of what you can expect from our discussion tonight. First, I'll give a little bit of a background of fertility in general. What are some of the options that are available as far as treatments for fertility concerns? What are the success rates you should anticipate? And we'll also have some time for questions. So as far as infertility, we generally start by asking a very comprehensive set of questions about your history to gauge, even from the history and hearing about your background, we learn a lot about what risk factors may influence one's fertility or what could be an underlying cause for infertility. And these are some of the major causes of infertility. About a third of the time, the issues are related to eggs. A third of the time, issues can be related to sperm in heterosexual couples. And also, there's some issues that can occur of everything in between the egg and the sperm meeting, as far as like where the eggs and sperm have to travel, like in the fallopian tubes, there can be issues there, or in the uterus itself, there can be concerns like fibroids or other structural changes in the uterus that may influence one's fertility. And this just sort of breaks down some of the testing that we look at for each of these concerns. After an extensive evaluation, up to a third of cases, actually, we don't find any identifiable causes for why someone may have issues getting pregnant. And that doesn't mean that there aren't treatment options for those patients. It mostly probably means that at this point, we don't have any tests that are sensitive enough to be able to identify what the cause is in that specific scenario. One of the most significant factors related to fertility is age. And so this is kind of a old study, and I want you to recognize that the important aspect here to understand is that unfortunately it's the age of eggs or female age that mostly influences fertility from the perspective of why people may have concerns getting pregnant. And unfortunately, that's related to natural physiology and how one, ages, because actually eggs, you're born with all of the eggs that you'll ever have. And as you age, those eggs will decrease in number, and that's just a part of the normal aging process. And we see that starting in the mid 30s and early 40s, there's sharper declines in fertility. And this is mostly related to eggs, unfortunately. When we talk about one's reproductive potential, we oftentimes use the term ovarian reserve or egg supply. And that term really refers to two separate aspects. One is the number of eggs that a person has or the quality of the eggs. And when I say quality, I'm mostly referring to how efficient are the eggs at creating healthy embryos. As one ages, the number of eggs do decrease, and that is somewhat predictable. And unfortunately, the number of poor quality, less efficient eggs increases as one ages. And that's why people are more likely to have fertility issues as they get older, because the pregnancies that are being created from those eggs, unfortunately, are not healthy enough to be able to either implant, or when they do implant, it can result in something like a miscarriage. So patients are also at a slightly higher risk for miscarriage as they get older, particularly once you reach the age of 40. And this slide breaks down natural pregnancy rates based off of age and also shows miscarriage rates as a result. And also, it shows the risk for chromosomal abnormalities. And remember, I said that the efficiency of the eggs as one ages can decrease, and that results in having imbalances or chromosomal abnormalities that are more likely to be present as you get older. And this just kind of shows that on in like a picture form. So in most cases, people have two copies of a chromosome. So this is showing two copies of each chromosome here. In this circumstance, there's an extra copy of chromosome 21, which is called trisomy 21 or Down syndrome. And this is a unique scenario because having an extra chromosome, which is typically thought to be related to the age of the eggs, is typically not going to be compatible with life. Either the embryo is not going to implant, or if it does implant, it could result in a miscarriage. And and trisomy 21 tends to be one scenario where it is compatible with life, but there are significant health considerations that are associated with trisomy 21. So when patients present to us with fertility concerns, we first evaluate the quantity of what we think their ovarian reserve looks like. And there's two ways that we're able to do that. One is with a hormone called anti-Müllerian hormone, and this is measured from your blood. The other is a special type of ultrasound where we're able to look at the ovaries and actually count the number of follicles that are present within the ovaries at that given time. Now, the number of follicles that we're counting doesn't necessarily mean this is how many eggs one has left or anything along those lines, but the number of follicles that are present correlate with whether the egg supply or egg quantity is high, normal, or low. And that's something I really want to emphasize, is that all of these tests tell us mostly how we would anticipate one would do if they were to go do fertility treatments and how many eggs they might get if they're doing things like IVF. But these numbers unfortunately do not predict fertility quite as well as they do fertility treatment response. And this image shows what an ovary looks like on a vaginal ultrasound. And these little black circles, I always kind of describe the ovaries as sort of flattened chocolate chip cookies, and the little chocolate chips are the follicles that we measure within the ovary. And so we can scan through, and remember, this is a 3D structure. So we scan through the ovary from side to side, and we can count the number of little follicles. And that gives us a sense of how high the egg reserve is. Now, quality of the eggs or efficiencies of the eggs are solely based off of age. So even if a person at a younger age, let's say 32, for instance, is having trouble getting pregnant, and then we find that their egg count numbers, their quantity is low, we still believe that the quality of those eggs and how they function is mostly going to correlate with age. And we have data that we look at for our patients because this clinic has been here for many years, and we have a lot of data that we've collected on how patients do when they do treatments. And so we're able to evaluate and see whether age or egg supply actually correlates with the quality of the eggs. And we find that age is really the most significant factor for that, and not so much the egg supply numbers or the quantity numbers that predict quality. Diminished ovarian reserve is something that we do see very commonly, which is where patients have decreased egg numbers and decreased egg quality. And in this scenario, unfortunately, older eggs and lower number of eggs are poor prognosis for being able to do fertility treatments. And there's no really good way to predict whether somebody will develop diminished ovarian reserve. And oftentimes we actually we will catch this kind of incidentally when people are interested in freezing eggs or creating embryos for the future because they're not ready to have children yet. And then when they're going through this process, we see these unfortunate consequences of diminished ovarian reserve. The other thing not related to fertility is that this may also have some prediction of aging because patients who have lower egg numbers may be at risk for going through menopause earlier, which has some clear health implications. So let's talk about what fertility treatments are available. And the three that we'll discuss are a combination of ovulation induction and insemination, or IUI, intrauterine insemination, as many people will refer to this as IUI. There's also in vitro fertilization, or IVF, and then egg donation, which we'll talk about that a little more in depth. So ovulation induction is something where you take medications, usually pills, that you take around 5 days in the beginning of the cycle. Or if you don't have regular cycles, we can sometimes just start at any time, which we sometimes see in patients who have polycystic ovary syndrome, who don't have regular periods. Sometimes those patients go months without getting periods. Um, and so these pills help the brain to work a little bit harder to tell the ovaries to grow eggs. Um, and people that will consider this are some patients who have unexplained infertility. As I said before, we've done a thorough evaluation and we can't find a reason why they have problems getting pregnant. Patients who have ovulation problems, this is probably the patient population who's most likely to benefit from this because we're fixing a problem that is clearly present, meaning that they're not ovulating. So taking medications that cause ovulation would be fixing that problem. Or patients who aren't ready to do IVF for various reasons. And usually patients will consider around 3 to 6 cycles of this treatment. And it's important to understand the success rates and how those compare to natural unassisted pregnancy rates for patients who have infertility or patients who don't have infertility. And we'll spend a little more time talking about success rates. So the concept behind insemination is that we're taking sperm that's from an ejaculated sample and we're washing that sperm, we're collecting sort of the best sperm, the best moving sperm, and putting it in a volume of fluid that can fit inside the uterus, which is then closer to the egg. Because in patients who conceive without fertility treatments, vaginal intercourse, there's lots of sperm that accumulates in the vagina, and a very small proportion of those sperm actually enter through the uterus and can reach the egg. So the thought is that if we actually, and I don't know if you can see my pointer here, but if we actually place the sperm inside the uterus, then that sperm is going to be closer to the egg, and the egg and sperm actually meet inside of the fallopian tubes here. So some of the success rates for ovulation induction and IUI, usually for patients who have a clear ovulation problem, like PCOS, they're most likely to benefit from this, where their pregnancy rates are as high as 20 to 30% per cycle, probably a bit closer to 20%. And versus patients who have unexplained infertility, there have been a couple trials and the success rates really range from like 5 to 10%. Now, it's important to think about what the typical conception rates are for patients who have infertility and don't have infertility. So, if you're not using any fertility treatments and you have no evidence of infertility, the natural conception rates are probably about 15% per cycle in patients who are less than 38. Now, in the setting of infertility, the success rates are probably closer to 5% without doing any fertility treatments in any given cycle. And so we have to think about those success rates and actually compare it to this. So these treatments are bringing those success rates in infertile patients a little bit closer to what the rates would be for patients who don't have infertility, but still relatively lower than some other treatments. So, what are some reasons why a patient might consider to do IVF? Many patients will start with doing ovulation induction and inseminations first, depending on their goals. But after they've done about 3 to 6 cycles, the data doesn't seem to show a benefit, and it seems that there's sort of a plateauing cumulative pregnancy rate that occurs after 6 cycles. And so, if you don't get pregnant after 6 cycles of doing this, it's unlikely that doing additional cycles are going to improve your chances significantly. Now, IVF takes out a lot of the things that prevent people from getting pregnant easily because, um, well, so to think about that, I'm mostly referring to patients who are getting pregnant without doing any fertility treatments. So the sperm has to meet the egg. The egg and the sperm have to create an embryo that is genetically balanced and healthy enough to implant. And that process is actually relatively inefficient. And when we do IVF, we're taking more eggs than would typically be released at any given time. So there's more opportunities for one of those eggs to become a quote unquote healthy embryo that can be implanted. And so that's why the pregnancy rates are higher than that of natural conception, because you're having more opportunities to get a good embryo to implant versus just releasing one embryo in any given cycle and having it be just based on that chance that it will be a healthy embryo. Patients who have low sperm counts, we are able to concentrate sperm numbers, or we're able to actually assist the sperm fertilize the eggs by a procedure that has been revolutionary in the field of IVF called ICSI, or intracytoplasmic sperm injection, where we can help the sperm fertilize the egg by injecting it directly into the egg. And that's been really helpful for patients who have low sperm counts or really abnormal sperm. Patients who have ovulation dysfunction, we're kind of correcting that by giving medications to grow lots of eggs, collect the eggs. And so they're not relying on their natural processes to be able to ovulate. Patients with endometriosis, there's data that patients with endometriosis have poorer pregnancy outcomes, but actually IVF corrects a lot of these things for them. And it seems that if you get a healthy embryo to transfer, the pregnancy rates are comparable for patients who have endometriosis or do not, suggesting that really IVF is bypassing a lot of the issues that endometriosis um, causes as far as fertility deficits when patients are trying to get pregnant. We also see a lot of patients nowadays who have known family histories of genetic conditions, things like cancer syndromes. For instance, BRCA is a cancer mutation associated with ovarian cancer and breast cancer. And as the field of genetics has grown over the past 10, 20 years, those technologies are getting better, and we're finding more patients that have been diagnosed with family histories of certain genetic conditions. And in some circumstances, people will seek our care just specifically to select embryos that are not affected by genetic conditions. And so that's not necessarily fixing a fertility issue, but it is helping them to overcome some really potentially significant conditions that impact their families. The last consideration is fertility preservation, where we know that age has an effect on fertility. And many patients will see us and try to get pregnant, but let's say that they desire more than one child in the future, we're now compounding the effect of age if they wait a couple years between this pregnancy and when they would want to get pregnant again. So some patients will choose to do IVF just so they have embryos potentially in one or two rounds of IVF that they can use in the future, and their eggs might be, well, are anticipated to be better quality and more efficient to produce healthier embryos now than they might be when they plan to try and get pregnant with their second or third child. So IVF can be broken down into these steps. The first is that we want to recruit multiple eggs to grow. So in a typical cycle, one egg will grow and become a dominant follicle, and that one egg will be the opportunity for pregnancy. In IVF, we're giving higher doses of the hormones that the brain uses to signal to the ovaries to grow eggs. And that causes more than one egg to grow, hopefully multiple eggs, depending on everybody has slightly different scenarios. But the goal is to get multiple eggs to grow. Then we perform an egg retrieval, which I'll discuss a little bit more in depth, but that's a procedure where we actually collect the eggs that we're growing in that cycle. So we're not collecting eggs from the future or like one's egg supply that they're not using currently. These are just the eggs that grow in that month and typically would unfortunately just dissolve at the end of that cycle. But with the higher doses of these hormones, it allows all of these eggs to grow instead of just one egg. And then we collect the eggs using a transvaginal needle that's guided by an ultrasound that is draining the fluid that the eggs are growing in. And I'll show you what that looks like in one of the subsequent slides. Then, once the eggs are collected, we're able to perform insemination, which just means allowing the egg and sperm to meet each other. And there's different ways to do that. One is where we grow the eggs in culture and allow multiple sperm to fertilize the egg. Where, sorry, we allow multiple sperm to be in the dish with the egg, and then typically only one of those sperm will fertilize the egg. And then I mentioned for patients who have poor sperm numbers, we have a technique called ICSI, or intracytoplasmic sperm injection, where we can actually inject the sperm into the egg to help it fertilize the egg. We then look to see, did the eggs that were inseminated, did they become fertilized eggs? And then we check to see, do those eggs grow over the course of 5 to 7 days into embryos? And these embryos are what we want to see. These are what would actually be transferred into your uterus. And we can look at the morphology of those embryos to see which ones might be healthier or more likely to implant. But we can also perform genetic testing on the embryos on the outer layer of cells that becomes the placenta. And that gives us some information regarding whether the genetics are balanced or imbalanced. And remember, that's the most common reason why an embryo would or would not implant. And so that allows us to select embryos that are more likely to implant. Embryo transfer is performed usually in a subsequent month because while we're waiting for the genetic testing to return, that takes like a couple weeks to get those results back. We actually freeze the embryos, and the embryos are frozen indefinitely until you're ready to use them. And as far as the data that we have, embryos can be frozen indefinitely and can survive that process very well. And so that's the last step, is sort of freezing the embryos and transferring any embryos during a natural cycle where you're growing an egg to support the lining to grow and allow an embryo to implant, or we give hormones in people who don't have ovaries, don't have regular cycles, we can give hormones to mimic the things that the ovaries would do to allow the embryo to implant. So this is what the ovaries look like, and you can hopefully you can appreciate that these ovaries here, those follicles are now measuring much larger than they did when I showed you that image earlier with the antral follicle count. Most of the follicles at that point probably looked about this size. And so in the setting of somebody who's doing IVF, we're trying to get multiple follicles to grow. And then this is the fluid that the egg is actually growing in. You can't see the actual egg on an ultrasound. This slide shows how the procedure is performed. So we use a transvaginal ultrasound that has a needle guide attached to it, and that allows us to see where the needle is going into the ovary. And so this is actually a video. I'm hoping the video will work. Let me turn off my pointer and then it might work. Here we go. So in this video, this is the needle, and we can see where the needle is going on the ultrasound. And the needle's in a follicle, and now it's draining that fluid. So that fluid there's suction that's applied to the needle, and that allows the fluid to be collected in this tube that's connected to the needle. And this tube is then passed off to our specially trained lab technicians called embryologists, and they look at the fluid to let us know, is there actually an egg in there? So fertilization is the next step after we collect the eggs. So this is an egg. There's little cells that are collected around the egg that have to be removed sometimes to allow us to either inject one sperm or allow multiple sperm to culture in the dish to allow one of them to fertilize on its own. So those are the two different ways we can do insemination. One is conventional, where you have the eggs in the dish with multiple sperm, or we can actually inject one sperm into the egg called ICSI. And this is a video that shows ICSI. So this is the egg here, and light suction is applied to the egg to keep it in one place. We position the egg in a very specific way so that this part of the egg called the polar body is facing at around 12 o'clock. This is the sperm inside of this pipette, and the pipette is actually advanced directly into the inside of the egg. They withdraw a little bit into the needle, and then you can see the sperm actually being injected in. So this was a game changer for folks who have poor sperm and poor fertilization, and has resulted in many pregnancies where otherwise we wouldn't see that. And this video now shows what an embryo looks like. So this is an egg. It has the little cells around it. And you're going to see that what happens with the fertilized egg is that we're going to start to see the changes that occur as we now see that this egg is fertilized. It has two pronuclei. And so that's how we can tell that an egg fertilized. We see two pronuclei, and then the egg starts to divide, or the fertilized egg starts to divide. First, it starts as two cells, and then it'll divide into four cells, and then eventually it'll divide into hundreds of cells, and then thousands of cells. And that's the type of embryo called a blastocyst that we would place in the uterus. That's a day 5 embryo. And so this is day 1, the two pronuclei. That's how we can tell if an egg did successfully fertilize with the sperm based on the presence of these two pronuclei. And then day 2, we would see a 4-cell embryo. Day 3, we would see an 8-cell embryo. And then by day 5, we see hundreds of cells. And this is the part, there's two parts of this embryo. This part is the blastocyst trophectoderm that becomes the placenta. And this is the inner cell mass, the part that becomes the actual fetus. So when we perform the genetic testing on the embryos, we're actually testing this portion. And this is just another video that shows kind of later in the process, the splitting. I always find this very fascinating to watch. So you can see all of these cells. So now at this point, all of these cells are considered the same, like they could turn into any type of cells that could form an embryo. And now we're starting to see differentiation into different cell types where it's forming that outer placental layer here. And then there's going to be the inner cell mass that's growing separately. And that's the part that'll become the fetus. And then actually what happens later in the process is, so this is actually, believe it or not, eggs actually have a quote unquote shell called the zona pellucida. And as part of the embryo growing process, the embryo breaks out of that shell, and that's called hatching. And so that's what's happening here, is that the embryo is actually hatching out of that shell and expanding. Now, remember I said that we sample the outer portion of the embryo that becomes the placenta to test for genetics, and that's what this video is going to show. As the embryo starts to hatch, some of those cells are extruded. So we're actually mostly just taking some of those outer cells that are being extruded with the goal to prevent any injury or harm to the embryo that's developing, that the part that becomes the fetus. And that's why we sample this outer part, because if we were to sample the inner part, we'd be concerned about the impact on the fetus. So we use lots of criteria for selecting embryos. Our data seems to show that the most successful embryos are the ones that become an embryo earlier in the process. Remember, I said we check the embryos on day 5 through day 7 after somebody has an egg retrieval. Embryos that grow and develop to the point of being ready on day 5 are more likely to be successful in implanting, and the pregnancy rates are probably closer to 65% for those. Versus embryos that develop closer towards day 7 are less likely to implant, but we still do see pregnancies from those, and they're still healthy pregnancies. All that the day really predicts is whether or not it will implant. So we do perform PGTA, or the genetic testing of embryos, for specific reasons. One is that it allows us to transfer one embryo instead of transferring multiple embryos. And some of you may know that like the field of fertility used to have more of a bad rap because people were getting pregnant with lots of babies all at once. And those pregnancies are very high risk pregnancies, because when you are pregnant with more than one baby, you're at higher risk for early delivery, or you're at higher risk for having complications associated with early delivery. And so our goal here is really to transfer one embryo that we believe is healthy at a time. And the other reason why we do PGT is to reduce the likelihood of a miscarriage, because remember, we said that miscarriages most likely occur when the genetics are imbalanced in the embryos. And so if we can check to see that the embryos have balanced genetics, then they're less likely to have a miscarriage, although it's still possible to have a miscarriage with a genetically balanced embryo. It's much less likely. And then we're also avoiding conditions that are associated with aneuploidy, such as Down syndrome. We're very proud that we follow the guidelines as far as what the American Society of Reproductive Medicine recommends, and they recommend that we only transfer one embryo at a time for the reasons I mentioned. And we see that our success rates are really good. So transferring multiple embryos actually doesn't really increase the chances of getting pregnant. It really just increases the chances of getting pregnant with more than one baby at a time and those associated risks, which I'll go into a little bit more in depth, although I mentioned some. So PFC has a long history of transferring one embryo at a time, and we are way above the national average of doing that, and we're very proud of that statistic. And this is the reason why, because twins have a 5 times increased risk of going to the NICU, 4 times increased risk of things like cerebral palsy due to preterm delivery, and as I said, higher risk for preterm delivery as well. There's other risks for stillborn, neonatal death, birth defects, and autism that have been associated with twins. And the preterm delivery rate for triplets and higher is even higher than that, over 90%. And so these are extremely high risk pregnancies, even more so than twins. And this shows once we've done the genetic testing and we have embryos that are ready to transfer, this is what the procedure looks like to actually transfer the embryos. So we place a speculum similar to when you're having a pap smear, and we place a catheter with the embryo into the uterus and perform ultrasound at the same time to be able to look at where the actual catheter is going, because we want to try and transfer the embryo towards the top of the uterus, which is where it will implant. And I'm going to show a video right now that shows what the transfer looks like. So this is the bladder, this is the uterus, a side view of the uterus here, and this shows the catheter within the uterus towards the top of the uterus, which is where the embryo is deposited. And we can't see the embryo itself, but we can see the fluid around the embryo, and oftentimes see what's called a little flash of fluid. And so this is the tip of the catheter. This is showing the catheter. This is the little flash of fluid from that catheter. So the process for transferring embryos is probably less intense than the process of actually growing the eggs and collecting the eggs. It's typically going to require less visits, and it'll also be a pretty minor procedure. There's no need for anesthesia or anything like that, versus the egg retrieval procedure is really the only day you kind of have to take off work and would need a ride because you're under anesthesia for that procedure to provide comfort. And as I mentioned before, we follow these guidelines. So these are the guidelines from the American Society of Reproductive Medicine on how many embryos they recommend transferring based on the type of embryos, blastocyst versus cleavage stage, and then also looking at the different like testing, whether testing was performed and the embryos are euploid, also known as genetically balanced. And so we generally, in the setting of euploid embryos, are transferring one at a time. And this shows our pregnancy outcomes for euploid embryos. And those outcomes really correlate with age, because we expect that the number of eggs we would get and the health of those eggs are going to correlate with eggs or with age. And so the pregnancy rates are highest for those who are less than 35, but they're still relatively good as we age. And fertility preservation, just to kind of briefly touch upon that, you you go through a very similar process to what I described, but we typically will freeze the embryos or eggs and use those in the future for IVF if desired, or many patients will choose to just try and get pregnant on their own if they have no fertility problems. Um, and some of the considerations that people will consider um, are outcomes. So we find that fresh embryos and frozen embryos have very similar outcomes as far as getting pregnant. And also, eggs are fairly similar to embryos as far as survival. Um, Traditionally, when people were freezing eggs or freezing embryos, eggs were not as successful in surviving the freeze thaw process versus embryos. But now with modern technologies that we use for freezing eggs, the rates of survival and use are pretty comparable. So another consideration for patients who may be advanced age or have low ovarian reserve counts, or some people will go through menopause early, or at expected ages, or even people who have had treatments that affect their eggs, such as chemotherapy or radiation therapy. All of these things can influence the eggs because unfortunately, eggs are really susceptible to toxins and to radiation, and it causes, um, unfortunately, irreversible damage. And so that's one circumstance where patients may consider using donor eggs. People who have gone through multiple rounds of IVF and unfortunately were not successful and or had miscarriages, even with genetically normal embryos, those patients will consider using eggs that have been donated. Or people who don't have a female partner, or for same-sex couples, we will oftentimes they will oftentimes use eggs as well. And a little plug, we do have an egg bank, which is unique to the Bay Area because no other clinics have their own egg bank. And so through the egg bank, there are lots of eggs that have been donated and are frozen and ready to be used when our patients need them, if they need them. And many patients will come to see us specifically because of our egg bank. And it has fairly high success rates. We work with it very closely, so it's pretty readily available for patients who are interested in using donor egg. And there's a lot of different programs that guarantee that you'll get an embryo or guarantee that you'll have an embryo that is genetically balanced, which is important when you're going through this process. And our success rates are very good for folks who have used donor eggs. So pregnancy rates, clinical pregnancy rates are about 60 to 65%. And cumulative pregnancy rates are around 40 to 45%. So these are very good for IVF pregnancy rates. So a little bit of background, just I want to end with some information about our clinic. So we really believe in patient-centered care. We don't use the same algorithms for every patient. Every patient is a different person. And as I mentioned at the beginning, we really take the time to get to know the patients that we meet with and learn their story, learn their goals, and think about not just the current goals for getting pregnant, but also your goals for the future and maybe trying to plan out and map out what your future might look like in addition to just what you're going through today. And we learn a lot in our consults about risk factors for fertility issues, or learn about, reasons why some treatments may be better versus worse for some folks. Financing is available, and you can meet with a financial coordinator to learn more about that aspect. We've had over 10,000 babies born from PFC. We've been at the forefront of technology as far as IVF and fertility goes, especially in the Bay Area. And we pride ourselves on staying very evidence-based, and some of us have appointments with UCSF and with Stanford, so we're engaged in teaching, and we like to stay at the edge, the leading edge of technologies to make sure that our patients are getting the best care. And these are our goals. And one of the goals I already mentioned was that our goal is one healthy baby at a time. And so we use all of these different ways to try and reach that goal. We have a location, our main hub is located in San Francisco, and we also have a satellite clinic in Marin. So this is our contact info. This is our handles for Instagram and for Facebook. You can follow us. Maybe that's how you found out about this webinar today. But at this point, I'd like to stop and pause and just take some questions that we have from the audience. So we have one question here that says, is there anything I can do to increase pregnancy through IVF? Get labs done, question mark, exercise, question mark, diet. So these are very common questions. And, um, overall health is very important for fertility. And part of what the the things that we see that influence eggs and sperm are healthy lifestyles. So people who smoke or have other risk factors that may influence their overall health can also influence their fertility. And so we always ask about those sorts of things. But the other thing is, like, in the Bay Area, we have a lot of people who are super active and don't really want to give up some of their exercise routines, and so we try to modify things that can work and also won't have a negative influence on your fertility, because sometimes too much exercise and dieting can have a negative effect on fertility. And so it's important for us to get to know sort of what your goals are and what your current routines are, and help to figure out best ways to allow you to continue to reach those goals, because many people find a lot of benefits from exercise for their mental health and things like that. So we want to allow you to be able to continue these types of treatments, or sorry, these types of activities, so that you're not feeling like just because there's fertility issues, we can't continue to do the things that make us feel better. Somebody said, can I start taking vitamins and supplements before I start the fertility process? So we recommend that every patient is taking a multivitamin, or even better if it's a prenatal vitamin. And supplements, there's a lot of supplements. If you go down a little bit of a Reddit rabbit hole, you will read a lot about supplements. One of the few supplements that has some concrete data behind it is called coenzyme Q10. And so we'll typically discuss that, and everybody's a little bit different, but most people, I do recommend start CoQ10 for both people who have sperm and eggs. CoQ10 is an antioxidant, and sperm and eggs, as I said earlier, are very susceptible to toxins and oxidants. And so that's the goal of things like antioxidants like coenzyme Q10. There's some other conditions where we recommend other supplements as well. But again, it's kind of more individualized based on the individual person. I saw another question. I'm going to stop sharing my screen here for a second so I can review it. What is egg retrieval like, and is it painful? Egg retrieval, I kind of mentioned the process. It's an ultrasound guided needle that goes through the vagina into the ovaries. And the reason is because that's the shortest distance to be able to reach the ovaries. And the skin within the vagina actually heals very well. So we don't actually have to suture, there's no incisions. So the procedure is not very painful. The symptoms that people experience who have gone through egg retrievals are mostly feeling the weight of their ovaries from the IVF process. So the ovaries become quite large as you're growing all of these eggs, and people will feel the weight of their ovaries and the discomfort associated with that more so than the actual procedure itself. The other question was about injections and are they painful? So injections are all subcutaneous, meaning that it's a small little needle, kind of like an insulin needle, that's injected into the outer like layer of adipose or fat tissue within, just below the skin. And so we're not trying to inject very deep, and the needle is very small. Unfortunately, all of the medications that people take to grow eggs are not able to be given orally because they'll get digested and not absorbed properly. So they have to be given as injections. Most patients become pros at injecting the medications, and one of the medications can sting a little bit when you inject it, but there's different tricks that we have to help improve those symptoms. But I'd say 95% of people have no issues with the injections themselves. Um, let's see. Another question that we have is related to AMH levels. And do AMH levels fluctuate? Is there anything we can take to increase AMH levels? So AMH levels don't typically fluctuate. There are some things that can lower AMH levels, um, mostly long-term use of birth control pills can falsely lower AMH levels, but they don't typically vary from cycle to cycle like some of the other hormones that we'll sometimes measure that tell us more about egg numbers and egg quality. So AMH levels don't typically fluctuate as much, and there's not, unfortunately, anything that can be taken to increase AMH levels. If somebody has been on pills for a long time and they're looking to do fertility treatments and we see the AMH levels are low, we'll sometimes try taking a break from the pills and see after a couple months if those levels do recover, which oftentimes they do. But unfortunately, we don't have anything at this time that grows eggs, and we're limited by what the ovaries contain. And that's unfortunately a reality that we don't have any treatments for. Maybe in the next 20 years or so, we might get closer to figuring out ways with better advancements and things like stem cells, uh, but at this time we don't have any treatments. And there are some treatments that have been proposed, like intra-ovarian PRP is one that's kind of very popular right now, or platelet-rich plasma. But there was a large randomized controlled trial that showed that it unfortunately didn't increase ovarian reserve. And so at this point, we don't do that procedure or recommend it because we think it could cause harm, actually. There's a question through your clinic, how long from start to finish is the process? And how much is it? Is it cheaper the second time if necessary? So I try to stay out of financials. There's some of this materials on our website, and you'll meet with a financial coordinator who will go through. As part of that process, there are some programs that we work with where they can bundle cycles. So let's say that we have a high suspicion that you might need to go through IVF more than once to get the number of embryos you would need. There are some cost saving effects for that. The other question was about how long does the process take? So as far as like once somebody is ready to start, if you're not doing any treatments in the month before, some people, especially folks who have lower egg numbers, we may do treatments in the month leading up to when you would start the actual injections to grow eggs. But let's say that you don't do that. Occasionally, the process usually takes about 2 weeks. And then so that's the stimulation, the injections, and presenting for ultrasounds and visits for that. And then the egg retrieval will occur within that 2 week window on average, sometimes more, sometimes less. And then we wait a couple weeks to get the genetic testing results back. So usually, and then the following month, so we have a rest month in between while we're waiting for the genetic testing results. And then the following cycle, if you have regular monthly cycles, would be the soonest that you would typically be able to proceed with an embryo transfer. And so from start to finish, it's on average about 3 months if you're going straight through from IVF to transferring an embryo. And a lot of this has to do not with our timing, but the ovarian timing and the uterine timing. And we're all kind of, I my my go-to line is that like we're all working on the ovarian calendar more so than we are on like a typical work week calendar. And so our clinic is open every day. We never close even on the holidays because ovaries tell us when they're ready to have the eggs collected, and same thing for when an embryo is ready to be transferred. As far as this last question I see here, is PGT required or can we choose not to do PGT? It's definitely up to you if you want to not do PGT. That's something that we recommend in certain circumstances, and there's pros and cons to PGT, and I certainly don't recommend it blanket for everybody. But there are some pros and obvious cons that we have to consider. And so when I'm discussing PGT with patients, I usually go through those and we decide whether we think that would be beneficial to them or not. So no, you don't have to do PGT. All right. Well, we have reached the 6 o'clock time point, so I want to allow everyone to continue their nights and thank you for joining us. And I'll let Stephen close things out.
Thank you, Dr. Strug. Thank you all so much for joining this evening, and we hope that the presentation was informative and helpful as you navigate your fertility journey. A recording of tonight's webinar will be sent to you by email tomorrow, so feel free to revisit the information or share it with someone who might benefit. If you have any follow-up questions, you're always welcome to give us a call at 415-834-3095, or you are welcome to reply directly to the email that we sent you. And then on behalf of everyone at Pacific Fertility Center, thank you again for spending your evening with us and wishing you a great evening. Take care.
Bye, everyone.